Blackwell, Chair of the Health Overview and Scrutiny panel, and I would like to welcome everyone to the first virtual panel meeting to be held by Portsmouth City Council. This meeting is being broadcast to enable the press and public to view the meeting. I'm very pleased to welcome back our co-opted members to the panel for this municipal year, and I should note that amongst the Portsmouth members there is a vacancy, as Councillor Hugh Mason is now a cabinet member, the cabinet member for planning, policy and city development. We are meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Until recently, the law stated that all members had to be present in the room to make formal decisions at meetings. However, the law was amended in response to the COVID-19 emergency, and councils are able to hold public meetings virtually. This will be in accordance with the local authorities' coronavirus flexibility of local authority meetings regulations 2020 number 392, the regulations. This is a new experience for most of us, and we will all need to exercise patience and understanding while we get to grips with these new arrangements. Those present are requested to keep their microphones on mute and to only turn them on when they are called to speak. This will limit the amount of background noise which can be disruptive. Members are requested to keep their cameras turned on at all times. May I ask officers and presenters to turn their cameras on only when they are presenting their reports or answering questions. Members and those who wish to speak should use the chat facility to write their name, followed by RTS, request to speak. Each time you speak, please say who you are so it is clear who is speaking. If there are technical difficulties, we will endeavour to resolve these and where necessary have a brief adjournment. But the meeting can proceed where quorate. I will now explain the running order for this meeting. After apologies for absence, members will declare any interests, then agree the minutes of the previous meeting. Then the panel will receive reports. So I would like now to invite those present to introduce themselves. I will read your names out, starting with members. Can you please reply by stating your name and saying present? I will pause for a few seconds between calling each person. Those who are not able to confirm they are present will be recorded as absent from the meeting. I call Councillor Lee Mason. Please turn on your microphone and introduce yourself.
Hi, Councillor Lee Mason, Caution Ward member and Vice Chairman. Thank you.
Thank you, Lee. I call on Councillor Graham Heaney. Please turn on your microphone and introduce yourself.
I'm Councillor Graham Heaney, Ward, Portsmouth. That was not muted.
Sorry, Graham, could you say that again?
I'm Councillor Graham Heaney, St Jude Ward, Portsmouth.
Thank you, Graham. I call on Councillor Leo Madden. Please turn on your microphone and introduce yourself.
Leo Madden, Nelson Ward.
Thank you, Leo. I call on Councillor Steve Weems. Please turn on your microphone and introduce yourself.
Steve Weems, Portsmouth Councillor for Drayton and Farlington.
Thank you, Steve. I call on Councillor Vivian Ashwell. Please turn on your microphone and introduce yourself.
Councillor Vivian Atchwell, Winchester City Council and Ward Member for Whiteley and Shedfield.
Thank you, Vivian. I call on Councillor Arthur Agate. Please turn on your microphone and introduce yourself.
Good afternoon, Chairman. Arthur Agate, Councillor, East Hants District Council for Clanfield Ward.
Thank you, Arthur. I call on Councillor David Keast. Please turn on your microphone and introduce yourself.
Councillor David is representing the Hampshire County Council.
Thank you, David. I call on Councillor Philip Raffaelli. Please turn on your microphone and introduce yourself.
Thank you, Chairman. Councillor Philip Raffaelli, Gosport Borough Council representative.
Thank you, Philip. And finally, I call on Councillor Rosie Rains. Please turn on your microphone and introduce yourself. No, Rosie's not here. Okay. Can I now please ask the officers and presenters that they are present as follows. Mark Coven, Chief Executive, Queen Alexandra Hospital.
Mark Coven, Chief Executive, Queen Alexandra Hospital, and present. Thank you.
Thank you, Mark. Nikki Adamson Young, Divisional Director of Operations for the Portsmouth and South East Hampshire Division, NHS Southern Health Foundation Trust.
Thank you, Chair. Nikki Adamson-Young, Director of Operations, Southern Health, Portsmouth and South East Hampshire.
Thank you, Nikki. Ron Shields, Chief Executive Officer, NHS Southern Health Foundation Trust.
Chair, I'm not, it's Nikki Adamson-Young here. Ron is my Chief Executive. I'm not sure he's been able to join us at the moment. I do apologise. He was expected, so he's obviously been held up.
Okay. Thank you, Nikki. Are you able to present if you can't?
Absolutely, yes. Just to inform you, Ron is new Chief Executive into Southern Health, and the report and any questions and briefing will be directed to me anyway.
Thank you, Nikki. Okay, moving on. Helen Atkinson, Interim Director of Public Health, Portsmouth City Council.
Thank you, Chair. Helen Atkinson, present.
Thank you, Helen. Andy Biddle, Assistant Director of Adult Social Care, Portsmouth City Council.
Good afternoon, Chair. Present.
Thank you, Andy. And Anna Martin, Local Democracy Officer.
Absent.
Anna?
Hello, I'm present. Anna Martin, present. Apologies, there was a technical hitch and I dropped out for a few minutes before.
It may not be the last. So, thank you, Anna. Mark, sorry, Coven, hi. Sorry, can I ask you to switch your camera off just while we, until you present your report? Thank you, Mark, thank you. And do all members have their microphones muted? That would be helpful. Thank you. Okay. Item 1. The first item is apologies. Have we received any apologies for absence?
Yes, Chair. Councillor Trevor Cartwright from Fareham Borough Council.
Thank you, Anna. Item 2, declarations of interest. Do we have any do members have any declarations that they would like to make?
Yes, I do, Chairman.
Yeah.
Sorry, it's Steve Weems. I work for the NHS, so I have a personal but non-prejudicial interest in a number of the items before the committee today.
Thank you, Steve.
Michael.
Oh, Leo, you there? Yeah, we can hear you. Your microphone's on.
Hear me? Okay, yes, I think I have one because I'm going to raise an issue in relation to the Portsdown surgery, right? So so yes, I attend Kingston Crescent surgery.
Thank you, Leo. And from me later on, we have oh, sorry, yeah, Lee. I think your microphone's on, off.
Michael.
Lee, so I think you're muted.
I've lost it.
I was saying I know I'm muted. I was just trying to get unmuted. Just for clarity, since Leo's declared his I'm also a patient with the Portsmouth group practice, like much of the city.
Thank you, Lee.
Sorry, excuse me, Chair. I'm Anna Martin. I have an interest with relating to the deputation because Mr. Dobson is a friend.
Yes, thank you, Anna. And in relation to the same deputation, Mr. Dobson is a resident in my ward, and I've met with him recently about some of the items that are contained in the deputation as well. Okay, moving on. Item 3, to consider the minutes of the previous meeting held on the 12th of March. The recommendation is that the minutes be approved as a correct record to be signed by the chair. Do I have a proposer for this recommendation? Anybody? Yes, thank you, Philip Raffaelli. Thank you. Yeah, thank you. Do I have a seconder for the recommendation?
Seconded.
Thank you, Leo. I will now take the vote by acclamation of the meeting as permitted within the regulations. If there is no dissent, the proposal is passed. Are there any objectors to the recommendation? Thank you. The minutes of the previous meeting have therefore been approved. We will now move on to the first report, which is an update from Portsmouth Hospitals Trust, introduced by Mark Coven.
Sorry, Chair.
Yes, Leo.
I had difficulty getting in, but I had a matter arising from the minutes. Can I do that?
Of course, yes.
It's item 22.
Which is?
Which was the CCG report.
Yeah.
And it was to do clearly with the, as I said earlier, it was to do with the merger of Hanway Road and Kingston Crescent surgeries.
Yeah.
I understand it has now taken place, i.e. the decision has been made. I'd like to know if we as a HOSP or you as the chair were actually consulted about this, because I think we made it clear in the past we saw this as a substantial issue and therefore needs the approval of HOSP. I mean, that's my understanding of it. But have we actually received anything officially telling us that the merger will take place?
Thank you, Leo. It's my understanding that we had correspondence on the 14th of April about the decision, but no further details were given.
Okay, can we about the decision? But did that 14th of April communication say that the decision had been taken?
I will have to look at the wording.
And if that is the case, can we as HOSP see the rationale behind it? Can we see whatever papers were put to the CCG?
Okay.
Thank you.
Thank you, Leo.
Thank you.
Okay. We're okay to move on to the first report. Yeah. Okay, sorry, back to you, Mark, for your report.
Thank you, Councillor. I beg your pardon, sorry.
Thank you for the report. We've all had a chance to read it. Are there any updates since the report was written that you feel that would be helpful for us to know about?
So there are a couple, because obviously the timing of the report, there's some new data that I'm happy to share, which is essentially around the current position at the hospital, and perhaps into just to reference some of the points in terms of our planning for the months ahead. So, but I'm happy to do that at whatever point is going to be most helpful, Councillor.
Thank you, Margaret. Well, if we could do it now, because I suspect there might be some questions that come out of what you might be telling us.
Thank you. So I think in addition to the paper, I mean, there's a couple of things I would just pull out and mention. So we now have, it's been a month actually since we had, thankfully, any further COVID-related deaths at Queen Alexandra Hospital. So it's been quite some time, and we now have just 4 patients that are in our care that have a diagnosis of COVID, which is obviously quite a considerable change. I think certainly since the last update that that HOSP received from Dr. John Knighton, my medical director, and I think is very significant in terms of our ability now to have much better insight in terms of, we have a much stronger testing regime for all patients that come into hospital, whether that's on a elective basis or patients who are admitted as an emergency, but also just due to the lower prevalence that there is in our community. So that's a most recent update in terms of where we are on the site. In terms of activity wise, for some weeks now we have been at near normal levels for emergency activity coming into hospital. So whether that's around the number of ambulances that make the way to the hospital, the number of admissions that we'd have for a medical basis, again back up to near normal levels, which is a really good thing, because at the early part of the pandemic, there were some members of our community, some patients who were at home, I think, with some conditions that perhaps they were a little bit anxious about accessing the hospital for fears of the risk of transmission. So it's really good and encouraging that more patients are using our services. We are still working out how we can do more activity on a planned basis, more elective and routine care. And we're having to balance a very tricky set of dynamics, which ensures that we can still follow very stringent infection control practices, and we can maintain the safety of patients, to continue to have types of treatment on an elective basis that are important. We have taken steps, and some members of HOSP certainly will have received a communication about this last week, and also may have heard reference or saw reference to this on the local news. But we are one of the hospitals and one of the local systems which is trialling out a new, essentially an appointments booking service through NHS 111 to ensure that appropriate patients obviously, but patients can access timely treatment, the right service, the right clinicians, outside of hospital or inside of hospital, but perhaps without the need to attend the emergency department, or if they do, it will be booked on a planned basis, rather than for those conditions that's appropriate, rather than just having to turn up to the ED without giving notice. So we in future, at a future meeting, perhaps we could talk about the impact of that programme, but I think it's a really exciting development, and one which I hope our community would support, because what we're trying to do is to reduce the time that any of our patients are waiting within the emergency department for access to see a clinician. So they're the things I would add on top of the contents of the report as you have them, but I'm happy to answer any questions that any members may have.
Thank you, Mark. So with the pilot, if I'm just jumping when I think about it, so what's the time frame? When's it starting?
Yes, so we are, it's going to be in different phases. So what we have started to do, so for any one of us who would normally call 111 for a condition, those patients that ordinarily use 111 will be essentially part of this programme, where there's all clinicians that are in will allow a clinical triage for that particular patient, and once the clinical triage is done, we'll make sure that the service that's available and appropriate for that individual patient's condition outside of hospital or inside hospital, that the 111 triage service can do that for the patient. So that's something that started last week. Now, what we are going to do over the course of the next couple of weeks is really ramp up. Now that the pathways are working, we are going to be broadening it out and stepping up some of our messaging to our local community in terms of how best to access some of these services, so that we will essentially encourage people to have a better use of the 111 provision. And that will allow us to do is to make sure that the kind of services outside of hospital, and again the ones that are inside the hospital, they're more directly accessible than perhaps they've been in the past. And with the booked appointment system in the emergency department, which we already have about 20 to 30 patients at the moment, since last week, 20 to 30 patients a day that are booking an appointment through 111 to come into the emergency department. And it's in a matter of hours. It's not like, in a couple of days. So as the learning develops and we're evaluating the patient experience of accessing the services, we'll start to broaden out the messaging, on local media to try and encourage the adoption of the 111 service.
Great. Thank you for explaining that, Mark. Members, do you have any questions?
Yes.
Yeah, Leo.
Chairman, are we using the raised hand if we want to vote? If you want to talk or vote?
Oh, sorry, David.
Yes.
Sorry, it's Leo first, and then we'll go over to you if that's okay.
No, oh, did you? Yeah. Okay.
Okay. Thanks.
I'm unmuted, I think, aren't I?
There you are. We can hear you, Leo.
It's modern technology.
It's fun.
Mark, thanks very much for that, and obviously we appreciate all the work that staff and the health service have done, and indeed other places. But there were a couple of things that I just want a bit of an explanation of in the report itself. One was in PPE, and of course these are coming from things that people have said nationally, but what you said that from the start, staff were appropriately protected at all times. Does that mean there were different levels of PPE? Some just had masks and some had masks, and people had more protection than that. And did any of the staff pick up COVID?
Apologies, Councillor, I missed the very last part of your question.
I just wondered if any staff actually picked up the COVID-19.
Okay, thank you. So with regards to PPE, we followed and continue to follow very stringently the advice that's been set out by Public Health England. And since the start of the pandemic, that advice on a couple of occasions has changed in light of emerging evidence about how the virus is transmitted and the levels of protection that's been provided to health and care workers. And in light of the new findings, the adaptations have been made, and we've been very, very prompt in terms of our, ability to enact those changes to policy. So I'm confident that as soon as we have been notified by national changes, national requirements for PPE, we've been able to put them in place very, very quickly. There have been, and I think everyone this meeting will have heard some concerns nationally about the availability of PPE. At the earlier part of the pandemic, as the supply chains to make sure that the right equipment was available at the right time were being strengthened. But despite those worries and the initial anxieties, and I think we all felt them from different perspectives, actually at different points, we didn't ever run out of any equipment that was essential for our teams to use. There were a couple of times where it was a little tight from day to day, but we never ran out of the equipment, which is really important to protect those, obviously, that needed the protection. Have any members of staff contracted the virus? Well, we had, just in the same way that we had, quite a high prevalence in the community. When we had some members of staff that were going off, either they were going off sick with symptoms of COVID, or they were in isolation because members of their family had symptoms and they had to self-isolate. When we look back and look at because we do have a population, part of the population, as you will have heard, that do not have symptoms, the classic symptoms of COVID, and what we call a group of people who are asymptomatic. And we've been able to look at the number of likely transmission from both. There's a test that's called an antibody test, which you may have read about or heard about, and the antibody testing tells us how many people have been exposed to the virus, and that number is greater than the number that had a confirmed positive diagnosis of COVID in the earlier parts of the pandemic, which obviously just reinforced the fact that there are a group of people, and I think we've heard and read a lot about this, haven't we, who do not have symptoms but have COVID and obviously pose a risk with further transmission. So I'm very confident again that with the testing regimes we have in place, that those individuals, certainly, so every patient that's admitted to hospital is all screened, everyone's screened. But increasingly what we'll start to do is look at how we test some of our health workers more proactively rather than only when they have symptoms. Does that make sense?
Yes.
Thank you.
Am I muted or not? I don't know. Could I just ask a question on planning for the second phase?
Yes,
one of the big national issues, of course, is people with cancer and people dying because obviously, decisions were taken at national level. How are you going to make sure that people do? You do mention the priorities in part 3, but how, particularly people with cancer, how are they going to be reassured that they will get treatment quickly and appropriately?
Yeah. Thank you. So this has been a big focus for us because what we wanted to do is to make sure that throughout even the peak of this initial period with COVID, that we protected urgent and cancer patient activity, because we know that this is so time critical for some conditions that it can make a real difference to a patient's life. And what we had to do is make sure that we had very individual assessments led by clinicians involving patients to make sure that the risks associated with continuing with a course of treatment did not outweigh, that there were more positive benefits with that rather than the risks that a patient could have if they were in hospital and ran the risk of a transmission with COVID. So we kept very close to normal levels of our urgent and cancer activity on site. The big challenge that we've had, there's been some kinds of diagnostic tests that we had to slow down because of the risks of transmission, which are gradually being stepped back up to normal. And some patients that have specific treatments for certain types of cancers, some of the chemotherapy regime had to be modified again to make sure that the balance was right in terms of positive benefit to patients rather than additional risks with COVID. But the key thing for us that has been a real challenge for some specialties, some cancer specialties, has been a reduction in the number of referrals into the service, and that is for patients who may have gone to see the GP with some types of a condition that they've been a bit bothered about, and then the GP would refer the patient into the hospital for those specialties. So I use our head and neck cancer specialty as an example, where there was a significant reduction in the number of patients that self-presented or were referred on from primary care because they weren't going to primary care with their condition. So it's something that we're very, very in tune with. We are working very closely with our GPs in primary care, and we've been supporting some of the national health messaging to try and encourage patients who have classical symptoms for these types of cancers to present to either to the hospital or to their GP as well. Just on the final point about cancer, we have 9 measures that we use to make sure that we're treating patients at different stages of their cancer pathway, from the point that they're referred into hospital for a check, when their cancer diagnosis is being made, or when treatment's provided. But there are 9 standards, and in June we hit all 9 standards for those patients. So for patients who are essentially coming to hospital, we are delivering everything that we need, but we have to continually assess that to make sure it's always in the patient's best interest to continue with the treatments.
Okay, thank you.
Thank you, Mark. David, hello.
Hello. Yeah, thank you. First of all, Mark, can I thank you very, very much for your staff, the fantastic work you've done over this period of the crisis. Certainly on behalf of anybody from Hampshire County Council and for East Hants, thank you so much. You've been part of a matter of understanding, you mentioned that 911 system and the triage being done over the phone is only through a 1 system, please.
So the sound wasn't very good, David. Is everybody else?
I don't think it's voice system. I've done about 10 of these. I don't have a problem.
Sorry, Mark. Did you get that? The sound here wasn't very good.
So, I heard you saying, expressing your thanks for everyone that works here, and I appreciate you saying that. Thank you, and I will convey those thanks. And I think I heard some of the question, which I think was related to the triage around 111. Is that correct?
Yeah, yes, correct. Yes, is it being carried out on the phone?
Okay, so if I have a go at this, and then you tell me if I've not quite answered it, if that's okay, Councillor. So the 111 triage service, it's a service that's run by our local ambulance service, but what we're doing is we're connecting up this service very, very closely with the support that we have in the primary care and with our GPs in Portsmouth and in South East Hampshire as well. And obviously the clinicians here at the Trust. And for patients who use the 111 service, in the triage area, this is in a call centre, we have clinicians with a range of backgrounds. So we have a GP, we have paramedics, there are nurses, there's mental health assessment support, we have a social worker in there, and there's even a midwife that actually works as part of the triage service, obviously for very specific conditions. So we have a very comprehensive kind of set of skills, so that anyone calling with, a particular condition or concern, we can navigate them very, very quickly to the most appropriate service or person that can help them as quickly as possible. So what we're doing is we're evaluating as we're going along to make sure that the place at which the patient is directed from the triage service, that we're just ensuring that the patient ends up in the right place, because for the first time, we will be able to see to make sure that patients get to exactly to the right place as soon as possible, instead of having to go to multiple services, which sometimes we hear feedback from patients that they get passed from one service to another. And that's something that we're very keen to make sure does not happen with the service, and it'll give us much greater insight to the services that are available. So I do think this is going to be fascinating, actually, in terms of how we remodel the kind of the way that patients access services outside of hospital, but also trying to have more patients accessing services directly inside the hospital rather than through the emergency department.
Thank you.
Thank you. Members, any other questions for Mark?
Yes, I have. I think some others did as well. I've seen a number of each.
Sorry, my chat, I don't know what. We might have to revert to the hand up option, I'm afraid. I don't know what's happening with that. Sorry, Steve, over to you.
A number of issues, I think. Firstly, in support of Mark, I can confirm to Councillor Madden, I had a close relative who attended during the COVID-19 crisis in respect of cancer, and he certainly received investigation and treatment, so I can confirm that's certainly happening. One of the things I noted was the A&E admissions, however. Mark said that they were almost up to normal levels. Now, it concerns me that might be the case whether it was before the pubs reopened, because I do know that A&E does suffer a lot with people attending with alcohol-related admissions. And the other question, more significant question, I suppose, was what lessons are being taken from this, because, as I say, I work in the NHS. I'm well aware that other organisations have taken lessons in terms of virtual outpatient appointments and the like. That certainly seems to have increased the flow of patients, and what lessons are being taken by PhD over this.
Thank you, Councillor. And so the first point around the attendance of the admissions through the emergency department. So I think if we look, one of the changes that we had to put in place quite quickly in the early days of the pandemic was to for minor injuries, is for the minor injuries service. I think John, our medical director, may have mentioned this last time when he presented. We essentially have asked patients who have a minor ailment or injury to use either St Mary's Treatment Centre or the Gosport Minor Injuries Unit or the one up in Petersfield, depending on where the patients actually live. And I have to say, there's been great support from our community to access those areas. Again, obviously for the types of conditions that need to come to the emergency department, that remains open 24 hours a day, of course. But we've been trying to do that as a way of trying to get for patients to have prompt access, according, for the right clinician to see them for appropriate for their condition. And when we look in the round, we have seen in total numbers, this is across the whole patch, for the number of patients that would have gone to one of the treatment centres or minor injuries units or the emergency departments, the numbers are down actually slightly in terms of attendances. It's just the admissions for the number of patients, because in the early part of the pandemic, we had some patients who were still, this is probably in the first couple of weeks, it was clear that they were, I suspect they were really worried about coming to hospital, and were probably having been more tolerant of some of the conditions that they had at home. Thankfully, within a couple of weeks, that settled down, and we start to see an increase of the number of patients that were coming through to us with, with the normal conditions, which have not gone away. Obviously, for things like patients who have chest pain, heart attack, and stroke, etc. So the numbers of patients that we would normally see have been, they're back up to normal levels and have been for about 6 weeks or so. So I'm pretty confident at the moment that the number of the normal workload that you would expect us to have and to see is back to normal levels, and we are coping well with the levels that we're seeing. We will continue with the minor injuries service for the time being provided in the way it is, because I think it just helps reduce the risk of more patients being in the emergency department at the same time, which obviously is not a good thing at the time being. Your second question was around the lessons learned, and there have been so many lessons that have been learned through this whole process. We've seen, we've talked about how, again, for appropriate conditions and appropriate patients, the way that we can perhaps do some of the things that we do in a slightly different way, and whether that's around, telephone consultations with patients, again, where it's appropriate to do so, or video consultations with patients. Whilst we've had some really good examples in some specialties where we've been able to do that, we have virtually overnight, we had to do that in order to make sure that patients could still have access to and get the right advice, the right guidance by the right clinician. And I know that's not for every single patient, and there are obviously conditions when patients need to come in for an assessment, a physical assessment. You can't do that virtually. But what we've been able to see is for those patients that have usually for long-term conditions, we can provide some support remotely in order to help them manage the condition and also provide the right guidance. So it's been a real, we're really keen to galvanise the opportunity that we've seen and to continue to make sure we've got the right kind of access for all patients. But that's just one example of something, a change that we virtually did overnight because we had to do that. And there are many more which, at another point in time, if you would like to know more about that, I'm happy to describe the range of things that we will be doing slightly differently. They're not things that service changes, they're just the model of care and the delivery that we would be providing, but they're all there as enhancements rather than fundamental shifts in access, if that makes sense, Councillor.
It does, it's all about the patient experience, I understand.
Yes, thank you.
Sorry if I might be permitted a supplementary, Chairman. As I said, again, sorry, I do work for the NHS, and I'm aware that Maggie McIsaac has made an announcement the last couple of days regarding Hampshire and Isle of Wight CGs merging with effect from 1st of April next year. Do you see that as in any way an issue for PHT? Because I'm conscious Portsmouth CCG is the one outlier who's not merging with everybody else.
So I think, sometimes I'm a strong believer that this is about, if we take the structures away, it's fundamentally about the working relationships day to day, isn't it? And I think if we have strengthened relationships between all of our partners, so that we're continually trying to think about how we have less handoffs, in terms of care for patients, more join up, because sometimes I think, and I say this not just being the chief executive of the hospital, but also, my mum, my gran, use services, I've used services in the past, and sometimes, I think most people get a bit frustrated, don't they, because of what's perceived to be the lack of join up between all of us in terms of providers sometimes, and I think, we have Nikki on the call as well. We're all continually trying to work better at collaborating together to make sure it makes sense for us to start to just build on the relationships and start to have more join-ups in terms of the care and the services we provide. So if this is a mechanism to help do that, I think it's fine, but we will continue with the relationships that we have. We have very productive relationships both with the city, with all of the services in the city, the CCG, and in South East Hampshire. 2/3 of our patients live in South East Hampshire. So I'm very confident with the relationships that we have and with the organisations that are involved in, the services that we provide, and we're all really passionate about continuing to work together. So I'm kind of, and I know sometimes you need to make structural changes because they just make sense to do it, but I'm a strong advocate. Relationships are what make things work, and as long as everyone's clear about what they're doing.
Thank you. Steve, is that okay? Good, thank you. Okay, welcome to Councillor Rains, and you were able to battle through all the hurdles to get here. Rosie, do you have any declarations of interest before we move on to other questions?
No, I don't, thank you.
Thank you, Rosie. Okay, I have Philip, Vivian, and then Arthur. So Philip, if you'd like to.
Thank you, Chair. I've got one comment really, and then 3 broad questions. So if you're happy, Chair and Mark, I'll do them sequentially so we don't get them mixed up with the communication. The first comment is upon the booking system going into the ED and other parts of the hospital. I think it's a great idea. I just have one note of caution. People's behaviours in the last 6 months or so have been really unique. I know our local CCG Community Engagement Committee, some years ago, they were floating the idea of trying to put all contact through 111. And to a group, all the patient contacts were against that as a step too much too far, and they all quoted the Police 101 as an example of how that can sometimes not work to anybody's advantage. So all I would really say is I think there are great opportunities, Mark, as you've alluded to a number of them, and I think the vast majority of people will be happy once it comes through. But if you ever do get to the point where this is going to constitute a substantial change in service delivery, then I think that needs to come back and go through formal consultation, etc.
Could you mind if I comment on that?
Yes, please. I'll do it one at a time.
So I completely agree with you, and I'm also one of the things I'm keen to just emphasise is our emergency department remains open 24 hours a day. Anyone can still walk in. What we're trying to do is just trying to, where we have an opportunity to, if there's an appropriate patient presented with an appropriate condition, we're trying to ask them to access the 111 service. So that's essentially it. And what we're trying to do is make sure we're really clear in the messaging is that we're not trying to take the place of GPs. So primary care, normally when you would just call the GP and you try and get an appointment for a particular condition, you still do that. It's not replacement for those kind of services. But I completely get the point that any permanent changes around this, after we've taken the right amount of learning, we will obviously come back to you where we need to.
Super. Thank you very much. Move on to the second point. I did want to add my thanks to how you perform the NHS generally, but locally I think you've been particularly impressive. And for what it's worth, I've got sadly a number of friends who have been receiving ongoing cancer therapy, and to an individual it's been remarkably well handled, so thank you for that. But what I did want to move on to though is normally the conversation with you is how's the discharge system going? Seems like 100 years ago, doesn't it? But quite uncomfortably, we talked a little bit testing earlier. Some of the earlier discharges before the testing regime was so hard, seemed to put some particular strains and stresses onto the social care system. Now I do know that between the bunch of you, you've set up Woodcote Lodge in Gosport a couple of weeks ago as a step-down facility, and that's really warmly welcomed. But can you say something about how it went during the early 2 or 3 months about your tested individuals or untested individuals being discharged into social care?
So thank you. And I know this is a really hot topic, and appropriately so, isn't it? You know, in the national conversations that are going on at the moment, and you know, when we were originally when the pandemic started, and you know, I was looking at some of the data earlier. Our first patient was in the 13th of March that was confirmed as with COVID, and then quite quickly afterwards the numbers increased. And you know, the early stages of the pandemic, you know, we had to increase our critical care capacity. So our critical care unit expanded rapidly, and it was up to 150% of its normal capacity. So we were preparing for an eventuality where even more patients would have needed to have access to our critical care unit, and we were preparing for having more patients who not quite go into critical care, but they had very intensive care needs. And to do that, we were still struggling at that point in terms of having, at that point in time, about 250 patients in beds, and who were waiting for some form of ongoing care. Now, there's not only a risk to other patients trying to access, you know, in the very acute end of our services, but there's a real risk for those patients who were waiting for ongoing care, the risk of transmission in hospital. So we worked very closely. There's a very clear national message around things that we needed to do in order to prepare for those patients to be safely moved into whether it was at home with some support, whether it was in nursing homes or care homes, and we will work very collaboratively both with Southern Health, with Solent, and with our local authorities, obviously in Portsmouth and in Hampshire. So we were working very closely to make sure that the protocols for discharge were really clear. We had some national changes actually and some legislative changes, which meant that, you know, the timeline for discharge was actually 3 hours. The standard's now 3 hours from a decision to be made for patients going on for some form of ongoing care. Now the testing, I should just mention, the testing regime at that point was very, very new, and the testing capacity that was available nationally, and indeed, you know, we became one of the testing sites eventually, because originally Southampton was our testing site locally. We only had enough tests to start testing certain groups of patients, and it was usually patients who were admitted with symptoms. As I said, you know, a little earlier, we now test every single patient that comes into hospital. We test them when they're in hospital for periods of time, and we're very clear about, you know, patients going into care homes and patients going into nursing homes, that they have to be confirmed as being negative with a swab for COVID before they can be safely discharged into that facility. Now that was not the case initially, because we did not know at that point in time the level of transmission that there was, I think, between patient populations. We didn't have full evidence. It wasn't apparent then, I don't think, that the level of transmission that was going on in care homes. I think it was not as clear in terms of the level of overlap between some parts of our workforce who moved between different parts of the care home sector. Yeah. And I think, you know, and we say this in hindsight, don't we? But I think the level of support that, you know, we need to offer, and I accept that we, you know, as an acute hospital, we are very specialist kind of areas for, you know, infection prevention and control. But I think increasingly what we've done over the past months is make sure that all of the expertise we have can be supported. You know, we can help support, you know, some care homes that are much smaller entities, because they may not have all the infrastructure in place at every point in time. Now, I know that's something that Nikki Adams-Young, who's on, you know, Nikki's infection control team, have been supporting as well. But I think, you know, in light of the learning that's been taken around this situation, I think some of the evidence, you know, that was available, that was guiding some of the national policy was not clear at the time, in terms of, you know, we didn't know about transmission, and we didn't really know. Some of the PPE requirements was different, and that changed over the first weeks and certainly months of the pandemic as well. So I know I'm giving you a range of different things there, but in truth, there are a range of different factors. But yes, it's I recognise the significant difficulties that posed at the time as well.
Yeah, no, thank you. That's actually very helpful, and I'm sure the inevitable lessons learned stuff, I'll get down into the crunching the data and cases specifically. But slightly linked to the infection control part, I mean, one of the very early things that you put in place is the restriction of no visitors. Yeah. I feel like it's one of the things that a lot of people ask me locally, so why can't I go and see my love partner or whatever? Are you near a point to reviewing the visiting policy?
We're staying very close to the national picture on this, but we're also what we've done, we've tried to broaden out some of the access points. So initially we were very, and we remain strict, I have to say. But so example, so we made sure that, you know, if we have a patient with who has mental health needs or learning disability, perhaps, what we're doing is making sure that, you know, the carers associated with those who are known to those individuals, patients, we're making sure that we can bring in, you know, the visitors who are going to be able to support and provide the right kind of, you know, calming kind of influence for those patients. When we were very stringent with women who came in to have babies with us, where we would just have one birthing partner, and now we have a birthing partner plus one other if they do want to. So, and certainly with we've kept access open as you, I'm sure, would expect, you know, for any patients who are unfortunately towards the end of their life. But what we're trying to do is make sure that we're making sensible conversations, because I'm not just making it just one person for that particular patient, but, you know, trying to think about, without having a whole family in, but a number, you know, trying to be sensible about how we apply the rules, because we recognise it's been really tricky for our teams, because, you know, the last thing we want is to deny anyone, you know, a number of us have probably been in hospital before, and certainly I've had loved ones in hospital, and the idea that you are not having that face-to-face contact with someone that you know and love, we've been trying to look at ways that we can supplement it. So in direct answer to your question, we're keeping this under constant review. I would expect that we would make some changes soon, but we'll probably make them gradually rather than open visitation up to everyone.
Good, that's very helpful. And very much the last question. Prior to COVID, we were still, I think, just beginning to catch up with some of the elective work, things like orthopaedics, from the previous winter when the wards were shut down.
Yeah.
Goodness knows what this is going to do to that looking forward. There is no simple answer, I absolutely get that. But is there already a conversation in the NHS generally and with yourselves about how to plan moving forward, and hopefully we can put this behind us so that, you know, everything from changing the list numbers, there's no point in having a totally unachievable number for you guys to achieve. That's pointless. You know, I think what we would like is realism of what's practically going to achieve, and as much publicity and openness, so we understand why it's going to take X weeks or months or even years now. That was it. Thank you.
Yeah, and so you know, this is going to be a real challenge for the whole NHS, isn't it? Because because of some of the facilities we've had to expand into when we, you know, in the height of our COVID response. So, for instance, we had to expand into our recovery areas as our footprint for critical care. You know, when we increased the capacity up to 150%, and that has reduced our ability in some areas to, you know, to obviously have other patients coming through for some of the lower risk kind of conditions. We've also been operating, we've been using the St Mary's Treatment Centre so that we have more space to play with, and we've also been using the local Spire Hospital. So our same teams, but we've been spreading them out to try and reduce the risk of transmission, and to try and get more patients through. But without a doubt, we have been doing far less work around our elective work. And again, some of that is in the patient's best interest at this point in time, but nonetheless, we have to keep a very close eye on which patients are going in next for treatment, because the last thing we want is, you know, for those what might be low risk procedures right now, but left too long, they can become something that's more urgent. So we have full clinical reviews of every single patient on our waiting list. But this is something that nationally we're wrestling with. Some of the equipment that our clinicians have to wear and the distancing practice that they have to follow means that we can't get through, even if we were working at full pelt, and we are trying to get back up to more, to get more patients through our hospital now to have the right treatment as per the original arrangements. unless there are some changes in terms of some of that, the guidance around the protection that our staff need to wear, and which is in the interest of each patient obviously being treated as well. It slows down the number of procedures that you can do in a theatre list, and we're working very closely again with Public Health England to see just what changes might be afoot in terms of some of the protection. But obviously, it's a very fine balance in terms of what we can do. But we're trying to do everything that we can, and we expect by the time we get to September, we will do a further step up in terms of the number of elective cases. But it is something that we have to keep a very close eye on. And I think, as you've said, being really upfront about what we can do. So we're trying to manage expectations for those that are in our care as well.
That's great. Thank you very much. Thank you for the detail.
Thank you.
Thank you. We'll go over to Vivian.
Yes, hello. Really appreciate all the answers you've given so far, and I want to give my personal thanks to the staff, because I was actually a patient in the hospital at the beginning of all this. The support I had was amazing. But some of my questions have been asked, but I just wanted to know what extra support the staff are getting. I mean, obviously this has been unprecedented times.
Yes, so thank you. So we've this has been something I've been really keen, and the whole of the leadership team actually been really focused on. We have we've invested quite a bit of resource to make sure that we talk about health and wellbeing all the time of our teams, but we've been really focused on the mental health and support we can provide to all of our staff, because not only have I think every one of us have been changed. Our lives have been changed in some way, shape, or form, haven't they? Whether it's around lockdown measures that we've all had to socially had to live with, or we've been affected because our loved ones, or we have had some real sharp end kind of experience with COVID. And there have been lots of members of staff who've been redeployed in other areas because we've set up other services that we didn't necessarily have before, but we needed to have in COVID. We've had some staff working in some areas where, sadly they've been seeing, not just patients who have, more intensive needs, but also some patients who've sadly have passed away in their care more than they would normally see in their professional kind of work life. So what we've been doing is we've been putting in more psychological support, and so we've had we've recruited, we're in the throes of recruiting some psychology support. We have some psychiatric nurse support. We've increased our occupational health provision, and we've been making sure that we're trying to proactively track those individuals that are more likely to be working in those more pressurised areas, as well as having some general offer of support and counselling advice available to all staff as well. So we've been trying to do lots of different things, as well as some really focused things. We have, as you know, the military work here with us, all three services, and we've been using some of the expertise in the military as well, with some insight about, in terms of the type of support they put in for some military colleagues who go into the field, and when they come back out, about how they will respond to some traumatic events. So we've been trying to put in a very rounded offer, but a number of you have said thank you to us, but I will just, if I may, just take the opportunity to say a big thank you. Our community has been tremendous throughout all of this, and it's one of, I feel in a very privileged position to do the job I do at the best of times, but this the way our community has really stood up, and really the support they provided to our staff and to everyone that works here has been absolutely tremendous, and I can't describe enough just what an impact that's made to the morale right through this very difficult period. I think everyone has felt it, and it's been really palpable. So that's just my way of saying a thank you to our community as well.
Right. Thank you very much. Thanks.
Vivian, any supplementary questions?
No, that's fine. Thank you. Thank you.
Thank you for that, Mark. Arthur, over to you.
Thank you, Chairman. Mark, two things from me. One is, again, my thanks to your oncology department. They've been looking after my wife extremely well every 3 weeks. You have had to exercise an awful lot of changes to keep your system going, there will have been a number of those changes, possibly that you will have identified, which will increase possibly your productivity in the future. Are you looking at these changes seriously with a view to some of them becoming identified as a good idea to carry on because it will increase productivity and you may possibly gain finance savings in that? Thank you.
Thank you. Thank you, Councillor. What we've been trying to do is to look to see, and I use the outpatient consultation as an example. When we start to think about the new way that we've been able to do some consultations, either on the telephone or virtually, like this, again for the right patients and with the right conditions. Things like we have some clinicians who travel between some sites. And some it can take many hours actually in a working week for those clinicians to move around the different sites that they cover. Having an opportunity to see bigger groups of patients, again appropriately so, through virtual means reduces things like the travel time between the sites, and therefore we've got more clinical time then to see more patients. So there are byproducts in terms of the new ways of working where we can get greater benefits. I think from an efficiency perspective. We haven't really mapped every single one of those out at the moment, because what we've been trying to do is we've been freeing the time up. We've readily been redeploying that kind of clinical time into more of the response that we've had for COVID. And certainly as we're preparing for, I think described in the paper some of the priorities for what we're calling phase 2, which is essentially trying to rebuild and restart some of our services. At the same time, what we're trying to do is really make sure that if in the eventuality that we see another rise in COVID prevalence in our community, we're able to step up in the same way that we were some months ago. So I think, picking up on your point, I think we want to track all the opportunities and benefits for future opportunities, but what we've been trying to do, instead of thinking of financial savings, what we've been trying to do is use the capacity that we generate to redeploy it in areas for the COVID response.
Is that okay?
That's okay. Thank you.
Thank you. Any other questions from members for Mark? Can I also add my gratitude to the team at Queen Alexandra who looked after me last year for 10 days, and the incredible ICU team who turned up just in the nick of time. So I'm extraordinarily grateful. Thank you. Leo.
Yes, I think there's no recommendation at all in this report, and I think very grateful for Mark coming. I've scribbled a few words, which I'm sure people will agree with, and it'll also apply, I think, to the future the presentation today. And I'd like to, I think, if everybody agrees, we put in record thanks to Mark for his report, and put on record our thanks to all the Portsmouth Hospital NHS staff for their excellent dedication and work during the current COVID-19 pandemic. Is that agreed?
Indeed, yeah.
Thank you, and thank you, Mark.
Thank you. Thank you.
Agreed. Thanks, Mark.
Thank you for your time, sir. I know you have another meeting soon. Thank you for your offer to come back and keep us up to date with the Call First pilot. I think
okay.
We look forward to finding out about that. But thank you this afternoon, and thank you for everything you're doing.
Thank you. All the best. Bye-bye, everyone.
Thank you.
Bye-bye.
Okay, we move on. We'll move on to the next report, which is an update from the NHS Southern Health Foundation Trust, introduced by Nikki Adamson-Young. Hello, Nikki. Welcome.
Hello, Chair. Thank you. Thank you very much.
Thank you for the report you submitted. It was when was it dated? 15th of June. So things might have. We've got a deputation. Let me. I think you have a bit of reading to do, Nikki.
Do I?
I'm sorry, excuse me, Chair. It's for the public health item.
Sorry. My paper's in the wrong order. Sorry, Nikki. Sorry to scare you there.
That's okay.
Thank you. So the report you submitted is dated 15th of June. So rather like Mark, Coven. Are there any updates of the last 3 or so weeks that you might want to update us with?
Yes, thank you, Chair. I think the key update is that we have a new Chief Executive in Southern Health now, Ron Shields. I do apologise, Ron was hoping to join us today, but he's been otherwise detained. I think it's just worth the councillors just having a really positive understanding that Ron joins us with a wealth of experience across mental and physical health services, and in fact he actually was the chief executive who saw Dorset Healthcare move to a position of outstanding, so we're really lucky to have him within our organisation and obviously within the wider constituency of Hampshire, so I think that's a really positive thing. So I just wanted to start by making councillors aware of that. In terms of the previous meeting, there's been quite a lot of discussion, and I know Nick, our then Chief Executive, gave you an update around the CQC action plans. I would just like to assure you that we are just now starting to revisit the work that we need to do around those action plans and assure ourselves that all the necessary plans are in place and progressing. Naturally, under the timescales and the challenging work that we've had of recent, we haven't had that same ability to be able to focus on those action plans, but just to assure you that we've maintained our governance structures throughout. We continue to work across very much with the partnership with our integrated care providers, so a lot of what you've just heard from Mark in relation to partnership working, and I know he made reference to my name and being involved in that partnership across Southern Health on a number of occasions, so just to assure you that those partnerships continue. Woodcott Lodge is one of those areas where Southern Health have been a key partner. Currently, I'm pleased to be able to report that we have completed the first phase of opening of Woodcott of 23 patients successfully being admitted into Woodcott, and I do believe we've also seen 2 of those being successfully discharged. I'm able to say anecdotally we've had some really positive feedback from patients around their experience of going to Woodcott Lodge, and I'm sure if that's something you'd like some more information on at a later date, Hampshire County Council, who are leading that across the partnership, would be more than happy to provide that. The other area that's worth particularly noting from previously is Southern Health, as part of managing our bed capacity in physical health and supporting the wider system, were utilising beds previously at Jubilee House, which was in Portsmouth. We're no longer doing that in view of the Woodcott Lodge programme that's been brought online. And that's now back with Solent, and the use of those beds are very much specifically for Portsmouth patients. We've worked very closely in partnership with ourselves and the local authority to develop the Turner Centre as a mental health assessment unit. So this was something that was brought about during the period of COVID as a response to help support the right patients arriving at the emergency department, as Mark describes, but those that needed more appropriate and more timely intervention around their mental health but no physical health needs. We identified that having the assessment unit was a means to be able to meet that need. That's something that we're now looking at following COVID and lessons learned and patient engagement. How can we use that approach in the system going forward? So again, internally we're discussing that at the moment across our partnership, and it's something that we would welcome the opportunity to come back and share with you at a later date. In terms of the proposals that have been brought forward, how that could be embedded as business as usual. I think the other area I would say in terms of mental health, and previously talked about in terms of our area beds model, is that I'm able to give you some really positive news in terms of how we are managing that area bed model and what that means for our patients and service users, is that we've actually halved the number of miles of distance from home to those beds for those patients, and we've been in a position where we've been able to reduce the length of stay significantly to a median of 12 days, despite the challenges that we've had when we've reflected on our information and looking at the referrals. We've doubled the referral requirement in the last 6 months to this time last year. But despite those challenges, we've continued to maintain a very good area bed position that's really improved the opportunities for people to be much closer to home, which counsellors will recall I've talked about on previous visits. We continue to now focus our work very much on the recovery phase. So all of our business, whilst some of that remains online because of the lessons learnt, it's the right thing to do for patients, and we've engaged service users with that. We're also very much moving back to face-to-face contacts where it's the right thing to do for our patients and service users, both across mental and physical health services.
Thank you, Nikki, and thank you for the offer to come back with updates later time on those issues. Thank you. Over to members. Any questions for Nikki? Steve? Okay, over to you, Steve.
Thank you. Just a couple of fairly short questions, I think. First off, notice what you said about the reduced length of stay was probably one of the reasons why that you've been able to eliminate out of area beds. Will this be able to be maintained? This is a very first short question.
We're hoping so. I mean, it's naturally a challenge in that we know it's the right thing for the patients and service users, and trying to do that is absolutely the right thing, but we've got to be realistic as well. Nationally, we've seen an increase in that demand now. And what we don't know at the moment, and we're just starting to understand across the whole of our community, is the impact from COVID in terms of people's mental health and well-being, and then any issues that may cause and raise for us in terms of the impact on bed capacity. What I am able to do, however, is assure you that not only across Southern Health, but wider across the strategic partnership, across what was the STP, the integrated commissioning collaborative services, we're looking at what that demand capacity requirement is across the whole of the Hampshire Isle of Wight, to be able to ensure that the right services are being provided to support those patients. But key to a lot of this work is absolutely what we're doing in the community as well. So the work we're doing closely with the primary care networks in supporting, the frontline primary care conversations and actions with our mental health partners and teams in those teams, and also more broadly with our community mental health team, and the work alongside that with our voluntary sectors.
Thank you. Going on from that, obviously mental health is a fairly large part of what you do, and I notice within the report you mentioned a fair amount of telephone contact with clients, but obviously especially for mental health patients, a large part of communication is non-verbal. And I just wonder how an assessment or judgment is made in those circumstances where you're not seeing a person, where we know mental health patients have and do mask their conditions, and yet if you see them, you can see they're more agitated than their voice portrays. So I'm just wondering how you will be able, how your service will be able to maintain suitable mental health provision in the coming months, because clearly there will be extra demand for the service, as well as the continuing and existing demand.
Yes, absolutely. And just to assure you, we are seeing the patients. So where patients either need to be seen because they are vulnerable and in that high risk category, that it's the right thing to do. If actually patients themselves are saying that that's the approach they want to take, that's absolutely what we're doing now. What we're doing when we're seeing them is obviously following the national guidelines in terms of social distancing and the correct PPE equipment. So it's not that those patients aren't being seen. There was a period of time, of course, that we all know when the national guidance and directive was much more stringent than that, but across the organisation now, as part of our recovery, we are absolutely reinstating those appointments. And whilst we're continuing to look at how we can use technology and do things smartly around remote working and other things, if that isn't right for that particular patient, then that isn't the approach that we were taking.
Is that okay, Steve?
Yeah, thank you.
Thank you, Nikki. Okay, I have Leo and then Arthur.
You're unmuted. Okay. Yeah, thanks very much for that, and thank you, Nikki, for the report. Can I just follow on from Councillor Weems' point, because I have severe reservations, particularly dealing with people with mental health issues, whether they're young or old, getting a call over the telephone. I mean, Steve's absolutely right. You know, it's looking at the person, looking at the white of their eyes, and find out if in fact they are quite telling the truth. So, I mean, I hope this is not something in the future, because I'm getting it with my own mental health, health issues, you know, telephone conversations, which I find totally unsatisfactory, I have to say. But I hope it's not going to be, it's not going to be a situation whereby the lesson to be learned will be that all we need to do, or all you need to do as an organisation, is have telephone conversations with people with mental health who've been on the cards maybe for some time.
No, again, just to reassure you, Councillor, that is not the approach that we're taking within Southern Health at all. And of course, any arrangements in terms of how we have contact with our patient service users needs to be done in conjunction with them and what works for them. And we're very keen across the organisation that we learn from this period of time, and some people have talked really positively about their experiences of having much more timely response because they can do it remotely and online, but for others that isn't right, and it is for us about getting that balance right, listening to that patient service user and finding the right approach that works for them. And so it isn't about just now saying we're not going to go back to doing face-to-face contacts. It's absolutely the opposite. Where we know it's the right thing to do, we're encouraging staff and ensuring that we give them the right support in terms of the equipment and the social distancing and the PPE to be able to do that.
Okay, thank you. I'll have lots of questions, but just one more, because I'm on the very last page of your report, and it's interesting, and I think you're the only one that said it. You say we are also reviewing all the work that we stopped. And to know what the impact of that was. That'll probably take a few months, but will we be able to see that report?
Yes, I mean that's something we're doing across the trust. So yes, of course, we can bring that report back to you in more detail.
Okay, thank you.
I think just if I may to add, when we talk about things that we stopped, I think a lot of that is more around business things that we stopped, as opposed to stopping seeing or having contact with patients. It was more about the actual, some of the process things as an organisation and things that we've stopped, but we will happily bring that report and information back to give you that assurance.
Thank you, Nikki. Okay, over to you, Arthur.
Thank you, Chairman. Nikki, thank you for the report, and trust me, I have read it, and in a number of times within the report you mention risk management. I find this is quite an important aspect for me, having been thrown into the deep end of this in 1986, by the insurance and the government, and the organisation I was involved with at the time. One of the things that has been fairly critical over the time is that ongoing training, particularly where legislation is concerned. Presumably you do have an ongoing system of training or updating risk management.
Yes, absolutely, we do. Across the organisation, risk management is something that is, within each of our clinical staff and corporate staff's responsibilities, that we have certain training programmes that need to be done, and of late, in terms of the national guidelines that have come out that have meant that we've needed to take different risk management approaches. I think Mark spoke earlier about the joint working across the system around infection prevention control and how we've done that together and supported each other in that mutual aid, and risk management and the decision making has been critical to all of that, and it will continue as business as usual. I think that the reference to it in the report is it's been something that's been given extra scrutiny at this time, rightly so, because of the need to respond and assure ourselves in terms of the national guidance and the responsibilities to support our staff and our patients.
Thank you, Nikki. Arthur?
Thank you.
Okay, over to you, Philip.
Thank you, Chair, and thank you for the report, Nikki, and your willingness to bring back so many of the things that other members brought up. I'm particularly keen to see a feedback in due course on Woodcote Lodge, which I think is funded till March, but it's the kind of facility we've so often talked about as being something desirable. It might be one good thing that comes out of this if it's something that can be maintained in the longer term, so that'll be interesting to hear. I was going to ask a number of questions about mental health, but you've thankfully dealt with those with other members. The one thing I would like to ask you about, though, is that clearly you've had to provide a fair amount of support to different care homes across the region during the time, and that, of course, is a two-way stream. I mean, I sit on one of the local, it used to be New Care Models, but it's now the PCN and Integrated Care Pathway groups, and I wouldn't go into any names, but it's clear that not all care homes have the same willingness to get involved in how to move themselves forward. Can you just say something about whether that's been a concern to you, and is this going to allow you to try and break through that and get a much more truly integrated across all sector provision as we go forward? Thank you.
Yes, thank you, Councillor. It has been something that I think we've moved significantly during this time for the good. As you rightly say, we have supported the care homes, so some of our staff have gone in and provided additional training. We've been able to look at offering different advice in terms of in a coaching style, and certainly the nursing homes and care homes that have been receptive to that have spoken really positively about it. We're working very closely with our clinical commissioning group and local authorities to support care homes, and within our system we've got a very detailed care home plan of the actions that we're doing to support the care home, which Southern Health is one part of that plan. My personal take on it is that I think it's quite difficult for the care homes as private businesses to sometimes feel that support that they're being given is meant in that way, in terms of offering support, as opposed to feeling perhaps when it's come previously through requirements from CQC and legal requirements to do things in a different way. That's been quite a difficult conversation, but I feel that during this time the experiences that we've had and the fact that we've been able to do that has built those relationships in the care sector, both for the local authority and ourselves and the care homes themselves, and I'd like to think that there's some real learning that we will take from this to be able to continue to support care homes, because we know that's going to be a challenge, as we move forward into winter as well, and the more we can do that together in that space, as you rightly say, the better for all of our community really, and all of the patients who need to move to care homes in long-term solution.
No, thank you. That's very encouraging. Thank you, Nicky.
Thank you.
Thank you. Arthur, do you have a question for Nicky?
Yes. Yeah. Sorry, Chairman. Right, Nicky, on your key learnings, the very last 2 lines, you asked a question. How much progress have you actually made on that?
Sorry, bear with me. I'm just going to my key learnings and the specific question that you refer to. Sorry, I'm having a technical issue trying to scroll down to that and look at screens at the same time. Are you able to be a little bit more specific to help me as I'm scrolling into that, Councillor?
Yeah, not a problem at all. What is printed is, could there be an opportunity to cement these changes to maintain productivity gains? Question mark.
Yes, and I think what I would say, and this is around the virtual communication with staff and remote working is what that refers to, and whether there's any opportunity to reduce costs around that. A lot of that is very much from a business point of view, so a bit like having this meeting now virtually. One of the things that we've done during this time is being able to connect with our wider leadership teams and do so remotely and in a more timely, efficient way, and also in terms of partnership meetings. So we heard from Mark earlier, and members from local authority are here as well. We've been able to do some of those meetings more virtually, and that's felt to be really productive. And if you start thinking, then we can do that without having costs of time, both to travel to a destination when we cover a larger geography, and also in terms of being able to reduce the mileage costs. So it's looking at it across the whole piece. And one of the things that we've talked about across the organisation and across the wider partnership is that kind of review that needs to be done now around any of the costs that potentially have been saved during this time by doing things differently, and then how do we reinvest that in the right places. So that's the commitment that it refers to.
Thank you. So actually the answer to my question is that yes, it's progressing extremely well. We shall look to see more of it in the future. Thank you.
Thank you.
Thank you, Arthur. Anything else from members for Nicky? Leo?
Just again, I think, Nicky, can we do the same as we did, Jimmy? Because all the staff, all in the health sector, have worked very hard throughout this period, and thank Nicky and thank all the staff on the same basis as the previous one. And I'll send a template to Anna. Everybody agrees. So it's the same thing, I think, because people deserve thanks. It's the very least we can do. If people are happy with it.
Agree with that.
Good, yeah.
Thank you, and I will certainly ensure that all our staff hear your appreciation and thanks. So thank you very much for that.
You're very welcome. I'm sorry Ron wasn't able to join us this afternoon, but please do let him know I'm looking forward to meeting with him next month.
I will indeed, and I do send his apologies again. Thank you.
Thank you, Nicky.
Thank you. Bye.
Bye. Okay. We move on to the update from Public Health, which I think is the item with the deputation. Are you here, Helen? Hi.
Hi, Councillor Atwell. Yes, I am present, and I am happy to start reading the deputation.
Well, let me just do the scripted bit. A deputation from Mr. Mike Dobson on behalf of the Friends of Old Portsmouth Association has been received regarding this item. The deputation has been sent to this panel, and Helen Atkinson will read it out before you introduce your report. There's a time limit of 6 minutes. So over to you, Helen.
Thank you, Chairman. Mr. Chairman, councillors, good afternoon. Thank you for the opportunity to submit a deputation. I also thank in advance the Interim Director of Public Health. It must be challenging for an officer to deliver a message when she has not met the person, so I hope she will be able to convey the concerns that I and many other clean air campaigners in Portsmouth hold. The deputation concerns only the part of the report about air quality. Last year, I made a deputation to Cabinet on the same topic. Councillor listened politely. I followed up with detailed analysis and evidence to support the points. Disappointingly, there was no follow-up from the Council, either collectively or by individuals. Meanwhile, time is running out to meet the High Court's overriding requirement to meet national air quality objectives in the shortest possible time, and I worry that PCC is sleepwalking into failure. Failure to comply with the law and failure to deliver clean air to improve the health, well-being and life expectancy of everyone in Portsmouth. Reducing the city's reliance on fossil fuel transport is also needed to meet the commitment underpinning the Climate Change Emergency Declaration. I would like to expand on some of the points in Dr. Atkinson's report. Firstly, too many cars. The elephant in the room is the fact that the number of motor vehicles registered in Portsmouth continues to rise year after year. The advantage of clean engine technology is negated by the popularity of larger cars such as SUVs with higher emissions. There is also a worrying increase in the number of light goods vehicles that are mostly fossil fuel powered. The rising number of battery electric vehicles is adding to the rising total of motor vehicles, but is not replacing the fleet of internal combustion engine vehicles. PCC's reluctance to contemplate curbs on the number of vehicles in our city increases congestion, making cycling more hazardous, makes walking less appealing, and puts increasingly unsustainable demands on road space for parking on an island that stubbornly remains the same size. Since I came to live in Portsmouth over 4 decades ago, the council has continually encouraged people to walk and cycle and use public transport. Meanwhile, all the time building new roads to make it easier to drive and neglecting the infrastructure needed for active travel. It's not just offering an acceptable alternative provided to private cars. The alternative has to be so attractive that it will encourage a large model shift and many drivers to leave their cars at home. Analysis of the annual Clean Air Day traffic figures for 2018 and 2019, shared with councillors and officers, shows how polite messages have minimal effect on the vast majority of car drivers. The Transport Recovery Plan report admits that motor travel levels are already back to 83% of pre-lockdown levels. The insatiable demand of more parking continues to compromise the health and sustainability benefits of major projects such as the South Sea seafront defences. Second, is the challenge of ensuring that any proposed CAS does not worsen inequalities. The conventional view in PCC is that a clean air zone would have harmful impacts on the poorest in our community. This view appears to ignore the principle of environmental injustice of air pollution. Last year I presented the evidence to Cabinet from both Public Health England and research by the University of West England that argues the opposite. The poorest pollute least, suffer the most from air pollution and will have most to gain from a clear air zone. To illustrate this, Charles Dickens Ward is on the border of the highly polluted Bratton Road and Kingston Road. And in this ward, 63% of households have no access to a car or van. People who already can't afford a car aren't in a position to upgrade to an emission-compliant vehicle. Instead, nearly 2/3 of these city centre residents have no option but to walk, wait for a bus or cycle in highly polluted streets, all the time breathing in the harmful traffic fumes produced by others. A CAS is designed to provide a rapid reduction in air pollution. Everyone in Portsmouth will benefit from the cleaner air, but the health improvement will be greatest for those who can't afford cars anyway. I will be delighted to share with councillors a reference and analysis to evidence this. Thirdly, the contradictory and assumptions of growth in road traffic. On many occasions I have given evidence to councillors and officers that different directorates in the council are using inconsistent figures. In 2016, the head of planning briefed the Traffic Environmental and Community Safety Panel that traffic was expected to increase by 4% per annum. Yet Portsmouth's air quality policies are founded on the Source Appointment Studies 2017 that form part of the annual status report. That study assumed that traffic will increase in Portsmouth by 0.4% per annum, only 1/10 of the demand assumed by planning. Different assumptions are used in the Portsmouth local plan and the air quality local plan, such as the Solent sub-regional traffic model. The last version shared with the public predicts that by 2031, car use in Portsmouth will increase by 0.8% per annum. that it is double the growth assumed in the AQ studies. Public transport will reduce by 8.4%, active travel will decrease. It seems there is a fundamental incompatibility that undermines the plan for a limited area Class B clean air zone. Planning assumes that the city's economy depends on increasing road capacity and demands more infrastructure for motor travel, whereas public health assumes that the infrastructure will be reallocated to benefit active travel and public transport. The place of these discrepancies to be resolved is the Air Quality Board. However, despite the Council's commitment to transparency, the Air Quality Board's minutes are not published. Please, would members of this scrutiny panel press for publication of the Air Quality Board minutes and briefing papers, and for the Air Quality Board to use one consistent figure of assumed traffic growth to be used in all planning, transport, public health and air quality studies. To conclude, Clean Air campaigners would like PCC to renew dialogue and to share all the information that the Council is using to plan its air quality plans. We would also warmly encourage councillors and senior officers to join us on guided cycle rides or walks around the city. We can show the patchy and substandard cycling and walking infrastructure, and also the locations where air pollution data are being recorded inaccurately, and so undermine the fundamental assumptions of the air quality modelling. Thank you, Mike Dobson.
Thank you, Helen, and thank you to Mr. Dobson for his deputation. He's asked for there's some action around the Air Quality Board minutes. I'll speak with colleagues and report back. I've also joined Mr. Dobson for a walk around our patch, and it was very helpful, very useful. Last week I'd encourage members to do the same for their patch. The deputation is noted by the panel. Thank you. Helen, over to you for your presentation. Thank you for what you've submitted already. Is there anything else you'd like to add?
Thank you, Chair. So I just wanted to update on 3 of the slides and then just give an overview. So just to say that I started in the Interim Director of Public Health role at the beginning of February. And soon after, as you are all aware, the COVID-19 pandemic arrived in the UK, and significant and substantial work pressures then, I suppose, fell on the team. And I want to thank the team officially at this meeting, because they have worked extremely hard both to meet the needs of our population and residents in terms of the work that Public Health lead on around COVID-19, but also we have maintained existing work. We have done that, as other speakers have said today, by delivering it in a different way, and we'd like to also thank our providers. So you'll be aware that we commission services from several providers, including our GP and pharmacists and SSJ, as well as other providers, and all of whom have ensured that they have delivered differently by looking at opportunities around digital response. So we've done a lot of our, particularly around our most vulnerable residents, our homeless population. We have provided, they have provided and ensured that care has been continued through using Zoom and telephone support. The only area really that we have had to stop delivering through our commissioning is health checks, but that was a national decision by Public Health England. So that was just as way by introduction, and then I would just like to mention 3 updates from the slides that I shared with you as you report. So in slide 3, which is the joint working around the homelessness and health, updates since we reported are that 60 people were successfully screened for, which is it refers to bullet point 2. 60 people were successfully screened for TB and other bloodborne viruses, including hepatitis C. So that is a significant success in this particular population group, and those that are identified as needing further treatment or care will be. And I'd like to thank again Portsmouth Hospitals NHS Trust and Public Health England, who we have done that work with. And also something that we're also incredibly proud of is, as the homeless, our homeless and rough sleepers moved into the hotels, the 2 hotels in Portsmouth, one of the areas that's identified is that they wouldn't be able to continue smoking in their rooms. So we've put on a vaping project and a vaping service that our wellbeing team have supported. And I'd like to say that 72 clients, and this data is as of the 1st of January, so last week, 72 clients have taken up the service and 16 have successfully set a quit date. So I think in this particular population group, who are both very vulnerable but also a particularly difficult population group for us to access, particularly around smoking services, this has been seen as a really good success. And then on slide 8, which is our joint working around air quality. Following the deposition, I just wanted to mention that I actually took over the role of chairing the board very recently. In fact, I have only chaired one meeting. But the focus at that meeting was how we really started to ensure that we equally prioritised the health outcomes from air quality. And we have had a successful conversation with Dr. Jonathan Lake from the Sunnyside Medical Centre, who is representing the Pompey Street space. And he represents many clinicians who have formally written to the council around air quality and improving it and active travel. And he has agreed to join us on the air quality board. He'll be joining us from the next meeting. So I think that is really positive. And then finally, on slide 13, which is our COVID-19 public health response. I know it's only one slide that we've added because I'm aware that we might be coming back at a future meeting to discuss the COVID-19 response. But I just wanted to say, since publication of the slides, we have now published our Portsmouth outbreak plan on the council website, with also a summary, resident focused summary, explaining what the outbreak plans are for. And so I just wanted to mention that because we did that in the, it was quite, we were asked following a government announcement to produce our local outbreak plans by the end of June, so we had about 3 weeks to do so, to really ensure that we are locally, and this isn't, although it is on the council website and it is a council-led plan, it is a partnership plan. So on the local health protection board and engagement board, member-led engagement board, we have obviously colleagues and partners from the Queen Alexandra Hospital, from Solent, NHS Health Trust, from our local CCG, Portsmouth CCG, as well as partners from the police, the port, and from schools. So it's quite a wide partnership, and it sets out, the outbreak plan sets out how we will mitigate as we come out of come out of lockdown, and as more people are trying to get back to, I suppose, a new normal life with social distancing. The outbreak plan is how we will respond to ensure that we are mitigating against increased infection rate. And I would just like to say that Portsmouth to date is in the bottom 10th local authorities in terms of rates per 100,000. So we have a rate currently in Portsmouth of 230.1, which is in the lowest. There are 140th of 150 local authorities across the country. So we have managed through the work that I think all partners have done, but also through the fact, and I would like to thank our residents, have obviously under extreme pressures, and I know very much a life-changing time, with people having to shield and socially isolate and remain distant from their loved ones. They have actually complied. We've had very good compliance rates. So I just would like to thank our residents as well, because I know it's been a very difficult time, as well as all of our staff and our partners' staff.
Thank you. Thank you, Anne. Thank you for the updates. Members, anything for Helen? With Leo, and then Steve, and then Philip.
Hi, thank you, Helen, for that report. I've just a couple of questions, really. on page 26, where we talk about drug and alcohol service, it said we've seen a slight increase in opiate users from it's up by 11. Is that worrying? Is that a worrying trend, or should we just shrug our shoulders at it? Hello? Am I mute? Can you hear me?
Okay, we can hear you, Leo.
Oh.
Sorry, I'm just going back to the slide.
Oh, sorry.
So that I can actually see.
Well, if you're on the slide, I'll do the other question then. The other question's on page 29. Our page 29, I suspect it's not yours. And it's to do with smoking, as you mentioned, and you mentioned homelessness and people in hotels and whatnot. Vaping versus cigarette smoking. I've read so many different theories and conclusions on vaping. You know, people think it's great. People think it's as bad or as worse as cigarette smoking because there's nicotine in the vaping, I'm told. Judge vaping. So I think you're putting that as a success. I've got a question mark over that. But can people like me then be affected by secondary smoking from people who are vaping in the high street?
Thank you, Councillor Madden. So I'll answer your first question and I'll come back to your second question. So yes, any increase in opiate use is worrying. However, I want to say that SSJR, our substance misuse provider, have worked incredibly well over what is actually a very difficult period. And to a certain extent, we have a high use of opiate and drug users in our homeless population, and the fact that we have been working so closely with them in the two hotels and with the provider has meant that we have had the ability, I think, to put more support to that particularly vulnerable population group. We know that drugs, is an increase in drugs around our community, and what we're trying to do is ensure that we have got both the ability to provide the services effectively and efficiently to those drug users, but also to reduce the damage and impact. But also we've had to do that at a difficult time where, particularly in our homeless population, they've had to try to support the treatment but also keep socially distanced, and we've had to work with the homeless and our rough sleepers in a way that keeps them and our staff, the provider staff, safe. So it is worrying. It's not a huge increase, but it is still worrying. And of course, we're also worried about the fact that we haven't perhaps always been able to have the contact directly with our increasing alcohol use, which we suspect has increased considerably during lockdown, particularly in those at home. So I think it's worrying, but we are continuously working with the provider to look at the ways that we can support and be innovative in that. And we do provide telephone support, but also telephone contact numbers to encourage people to seek help and support. And then in terms of vaping, yes, so the evidence is really clear and very strong that vaping does much less harm to individuals than smoking. Now, vaping itself, you aren't smoking, you are using an inhaler, an equipment, but it is actually the nicotine that you're inhaling, which is not nicotine is not what does the damage in terms of smoking. It is tar that does the damage to your lungs, and also, in effect, thickens your blood, which also causes many, risks in terms of coronary heart disease, cancers, etc. So vaping itself is not as harmful as smoking, and also there is no current evidence that vaping creates secondhand smoke. I know it does. There is smoke coming out, but it isn't smoke that includes tar. It's just got the nicotine in, so it doesn't cause any long-term health. And in fact, we also know that there is a direct link between smoking and having greater, I suppose, well, you're going to have lung damage, so I suppose it is fairly obvious, lung damage, which means that you're more at risk. When you're not necessarily more at risk of catching COVID-19, but if you do get COVID-19 because you've got your lung function is impaired, you are going to get, it's going to have more damage, and you're going to be more unwell. So I think that's really important, which is also another reason why we're working with our homeless people to encourage them to stop smoking and take on vaping. And it is now part of the Public Health England guidance in terms of supporting people to quit smoking. Vaping is actually now used as part of the treatment regime.
Okay, thank you.
Thank you, Leo. Steve.
Thank you, Chris. First question is on the mental health and emotional well-being element, where you've got suicide prevention programme. And I noticed amongst it, priorities include bereavement, debt, financial hardship, and real-time surveillance. Now that conjured up pictures to me of FBI agents in cars parked outside. I just wonder what real-time surveillance actually entails.
Yes, thank you, Councillor. So basically, every single local authority has to produce a suicide prevention strategy, which we have done. We work very closely across the whole of the Hampshire and Isle of Wight. All the leads work very closely together. What we do is we don't routinely publish suicide data, so it's not necessarily in the public domain, but what we do is work with the coroner to understand the lessons learned from every suicide. So we do look into every single suicide that occurs, look for the lessons learned, how we can take the lessons into avoiding future suicides. We also ensure that we have agreements with local media to ensure that they're not publicising suicides, because we are trying to actually prevent, particularly in young people, suicide being glamorised or hotspots. So we do look at the data, and we do obviously follow up every single suicide in terms of understanding the lessons, because you'll be aware that not every, I think this is generally known now, that quite a lot of people that do commit suicide often haven't been known to mental health services. So it's trying to understand how we can actually put in place prevention measures to support people from not making that choice, because every suicide, however small the numbers, is tragic, obviously.
As an ex-Samaritan, I fully understand. It was just curious wording, that was all. It made it the way it made it seem. But the other question I had was regarding the conflict between smoking and mental health, because I'm conscious a lot of mental health patients use smoking as a distraction to help improve their mental health. Now, their physical health deteriorates at the same time, I appreciate. How is that circle squared? I think is the question I have.
So I think it is fair to say, historically and traditionally, I mean, I'm talking many years ago, mental health services used smoking, or in effect encouraged their patients with mental health issues to smoke, because it was seen as exactly as you say, that it improves people's mental health. Well, we clearly know now that that is not the case, and that smoking causes worsening of mental health and of physical health, and in fact, actually, those people who smoke are more increasingly likely to have mental health issues. So we know that there is that, you know, I think that is very well known now. So actually, we work incredibly closely with our providers, including our GPs, to actually discourage people from smoking and support people not taking up smoking or actually stopping smoking, particularly those with serious mental health issues. And also actually just to say our learning disability community as well. So again, smoking was used or seen as a positive many years ago, I'm not talking about now. And we all know that smoking is the leading cause of health inequalities and the gap in life expectancy. And we know that people with serious mental health conditions die up to over 10 up to 20 years earlier because of this lifestyle behaviour. So really what we're trying to move to, and all of the work that we do in public health, is to move to a no smoking society. I mean, that is what public health are trying to do, because we know it is the leading cause of early death.
I understand. I understand completely what you're saying. What I'm suggesting, though, is those people already with mental health problems use it themselves as a means of distraction, and when they've already got one mental health problem, trying to discourage them from smoking feels to them counterproductive. And that's a difficulty, and I accept that's a difficulty, but I don't know how that can be countered. That's what I'm trying to say.
I think it's really focusing on working both with mental health service users and with the providers of healthcare to mental health service users. That's from primary care up to acute mental health services to discourage. So we've done a lot of work nationally, regionally and locally to work with our mental health providers to actually move to smoke-free NHS, smoke-free premises, as you know, and it is trying to, I suppose, change that understanding. So I know that I am not a smoker, so I recognise it's difficult, and it is quite difficult. I mean, you can't really be a smoker as a director of public health for obvious reasons. You can't. You have to practice what you preach. But I think a lot of people who smoke, because of the nicotine, even though it is the nicotine addiction that gives the sense of. So people have nicotine addiction. They want to have a cigarette because it eases and they feel calmer. But actually, that is a miss. It's just actually relieving nicotine craving rather than the stress. But people don't, unfortunately, see it that way. But I think we just have to continue doing. We take I suppose, a multi-faceted approach. You know, it's about national campaigns locally. It's about working directly. And we know that some of the most important elements is actually your healthcare provider actually advising and supporting. We know that a brief intervention from your specialist is very effective. So that's what we encourage to do, work with our colleagues. We do a lot of training around stop smoking support to our NHS colleagues as part of that work.
Thank you. Although, of course, NHS colleagues can be some of the worst.
Yeah, I agree. I think it's fair to say that there was a huge culture of smoking in the NHS. I think that is shifting, hopefully, nowadays. And we've done quite a lot of work, again, as I've said, to try to encourage because it's not a great advert, is it, when your GP or your surgeon tell you to stop smoking, and as you're leaving, you see them at the back.
Lighting up, yes.
Lighting up. It's not a great advert.
No, indeed. Thank you.
Over to you, Philip.
Thank you, Chair. And thank you for your presentation, your notes. I'd like to just ask you a couple of questions, if I may, on your public health response to test and trace, and how well resourced you think you are for that. There's been a fair amount of speculation in the media that some of the communication of detailed data coming down from PHE hasn't necessarily been to the geographical specificity you require. And then just a final one. I was at the Hampshire County Council Health and Wellbeing Board last week when we had the chief executive from Northants Hospitals, where they've been trialling the OptiGene isothermal lamp testing system, which is highly specific and sensitive, and will give a test within 10 minutes. They're now reporting in the media this is being rolled out. But the kind of examples the chief executive was talking about is they've turned up with a van, a lab in a van they called it, to our care home, tested all staff members, all residents, and they all had the results, positive or not positive, before they left. It sounds like one of the really potential great breakthroughs, and I was wondering whether that would be coming our way soon. Thank you.
Thank you. So the first question around test and trace and capacity. So test and trace encompasses quite a lot of functions. Obviously, it includes the contact tracing, and I would like to say that is well resourced. So nationally, there has been a contract with Serco. This is a national decision, obviously, not local. And there's 25,000 telephone call handlers dealing with the national test and trace, who are taking the routine, what we call routine people coming through the telephone, and also the website. So what we call non-complex cases they're dealt with through that what we call level 3, and then locally there are 3,000 also to say specialists from Public Health England supporting that, and then locally the contact tracing is delivered by our local, so level 1, our local health protection team of Public Health England, who we work very closely with, and they have 4 times the capacity than they would normally have to cover that. But I think you asked a specific question about the data. So if you'd asked me 3 weeks ago, I would have agreed with you. Luckily now that has changed. So just around the time of the Leicester outbreak, so I know it was covered a lot due to the learning from Leicester. At that point, we were only receiving numbers, and we could actually get that information from the national website as well as everybody else could. So we were only receiving the numbers from Pillar 1 testing data, which is the acute hospital, and then and patients. But about the week that Leicester, it was the week just before Leicester went into lockdown, there was an agreement that we have been asking, so local DPHs, Directors of Public Health, and local resilience forums have been asking for more, to have access to the granularity, the data with its granularity. And we were asked that week to sign a data sharing agreement with Public Health England, and that week we started to receive the Pillar 2 testing data. So we now get that every day, and also once a week we get the what we call granular data, which has got it has got postcodes, age and sex, and we are hoping that at some point in the future we will also get ethnicity, because as you know we have got a big focus on supporting our BAME community because they are at higher risk from complications of COVID-19. So we are now getting that on a weekly basis, so that we are able now and are starting to map the confirmed cases of COVID-19 in Portsmouth, and actually in all of the local authorities in Hampshire and Isle of Wight and nationally. So yes, we have got access to that data now. And then your final question was about, yes, we're all looking on quite jealously of the Hampshire's lab in a van, because we don't have access to that now. So it's fair to say that testing has been led nationally by the Department of Health and Social Care. We are going to get more, I'm going to use the term control of the testing capability as we move forward with our local outbreak planning and our local outbreak plans. But at the moment, we are reliant on that, on the national testing. But we have a lot of testing capacity locally now. I think people were quite critical of that at the beginning of the pandemic. But we now, just to give you an example, we obviously have the Pillar 1 access through the acute hospital, and also through a mobile testing unit that is commissioned by the CCGs. We also have the Pillar 2 Hampshire and Isle of Wight TIPNA testing site. We are part of whole care home testing and have been since the beginning, and managed to get pretty much all of our over 65 and dementia care homes tested by the June the 6th deadline, which we were all asked to meet. And now that has opened up again, and we will be doing testing of every dementia and over 65 care home in Portsmouth monthly and staff weekly as part of that programme. And we will be bringing extra care and living online as well. And then we've just been approached to, we've been approached and have piloted a couple of areas that DHSC have been leading on. So we have the ability to test our domiciliary care staff providers over a month ago, which was really helpful because they're not part of currently, or were not part of any testing of the project. And we've just got the go ahead, and we'll be testing all of our homeless and rough sleepers in our hotels shortly, which I think is part of a national pilot. And we're also being given the ability to, as we move forward, to get more testing capability. And of course now everyone in their home, when they have symptoms of COVID-19, can go through the test and trace and get a home test sent. So I think the capacity and capability for testing is pretty good now. But obviously you're right, the speed is important. I think it's fair to say there was quite a lot of criticism early on in the time for some elements of the testing results to get back. it's fair to say we haven't seen that more recently. So the testing results target is, I think, within 48 hours, particularly from TIPNA and our whole care home testing, and we pretty much kept to that. I mean, we're not providing it, but we have managed to get the test results back. So I think that testing has speeded up in terms of the results. But yes, I think as it further develops, the testing capability, including pilots like the Hampshire Hospital Trust one, will be rolled out, hopefully.
Thank you. That's hugely encouraging, and I really wouldn't underestimate. We almost came from a standing start, didn't we? And to put in place this capacity is a real testament. The one bit in the middle that just makes me cringe a little is, the delay in sharing data until you'd signed data sharing agreements. The GDPR is a wonderful bit of legislation, but it's far from the only example we've got during this pandemic when it's actually delayed the ability to help people as actively and as quickly as we want them. An example at our side was we couldn't get our hands on the local list of the sub-list of the shielding patient list until we'd signed it. It took 10 weeks for that. So if there's a lesson, one other lesson that we should all like to learn out of this is we need to have in place these data sharing agreements in advance of something happening. But I think that's a really good story, and I'm really encouraged by what you're saying we now have in place. Thank you.
Thank you. Graham, over to you.
Thank you, Chair. Helen and I have been at the previous meetings when she's given a comprehensive story of what's been going on, so I'm not going to ask any detailed questions about that. I just want to briefly comment and say, before I go on to my main point, that the work with the homeless people have been really, really effective. I think it's a strange set of circumstances that allowed us access to people who not normally have been able to get access to health, cleaning and care, and that's been a real good outcome, if you can say a good outcome of what's been happening in recent weeks. I suppose the challenge will be, once things begin to settle down again and people get moved on, is keeping those contacts going so that they continue to have good health and on to any problems they have. They need to keep contact with them in a way, not lose contact again, as might happen. I want to just say something about the issue of air quality, really reflecting on what I just say on the deputation. I think Helen's slide.
Oh, Graham, you muted.
Seems to do it automatically when I don't. I'm sort of yeah. So your slide captures the essence of the problem with air quality, in that you say it's an infrastructure problem in your slide, and the issue is how we persuade people to change their mode of travel when we don't have control over the infrastructure and the means of of different forms of transport. And I don't know what the answer to this is, because it seems to me we can make small changes, and we can certainly try and do things like increasing cycle routes, making them better. But ultimately, unless there is going to be a real incentive, i.e. to move from cars to other forms of transport, it's going to take a very, very long time to change habits and behaviour. It seems to me that the way things are at the moment with the quality of public transport and the COVID epidemic is actually discouraging people from getting involved in public transport, because people don't feel safe. There's restrictions on the ability to use it, and we don't know how long that's going to go on. So that's going to be another thing working against trying to improve public transport. I don't know if Helen can say anything about how long we think this restriction on public transport is going to go on, because unless we can change that, it's going to be much more difficult to move people into different modes of transport. And do you have any idea as to how we might move forward on that?
Thank you, Councillor Heaney. I'd like to just mention, because I think it's an area that we really, particularly in public health, but I think everybody wants to do, is at the beginning of lockdown we saw a huge increase in people taking up cycling and walking and a lot more active travel around Portsmouth. And we want to see how we can maintain that and move it forward. But I do recognise the point that Mr. Dobson makes around the fact that we also know that there is increasing, going back to pre-lockdown levels. So we did see a huge decrease. As you know, Councillor Heaney, I only arrived in February, and air quality and air quality board is something I've just taken on, and it has been rather busy with COVID. So I would like a little bit of time to give that some more thought, and that's why I wanted health to become much more part of the air quality board and how we were following up. So I'm going to be, it's a bit naughty because I haven't actually had a chance to speak to the Chief Exec at QA, but as an example, I think there's some areas that we want to get the NHS more part of the work that we're doing around improving air quality and active travel. So just as an example, a bit naughtily, I'm going to say that there is some evidence and some work that the Royal College of Physicians have done that say that 1 in 10 journeys currently are to do with health. So either people going to work in the health service or people visiting or actually accessing healthcare. And I think Mark mentioned it, and I think the Southern colleagues mentioned that actually one of the things that we have gained is looking at opportunities for providing digital innovation for how people access healthcare. I'm not saying that it needs to replace clinical face-to-face when that's important, but I do think that one of the things we also want to do, hence why we've invited Dr. Jonathan Lake to join us, is work with our NHS colleagues as a part of the problem, but also as a part of the solution to how we can actually reduce the need for travel. So it's not completely answering your question, but I think we need to start thinking a bit creatively, because we, as you say, we don't have control of the whole picture, but the elements that we do have, and I do think Portsmouth is a really good example of really strong close integration working and close relationships between health and local government, and we need to look at all of the opportunities we can use. And again, I think that we need to look at being really innovative and thinking differently, and we know that it is possible to change behaviour, because I wouldn't want there to be, I mean, I'm not suggesting that we have another pandemic, and we are expecting a wave 2, but I do think we've had the ability to change behaviour. How can we understand why that, and make best use of understanding those changes in people's behaviour. But I do recognise at the moment that there is quite a concern around public transport, and public transport is one of our, I suppose, alternatives to getting in a car. And whilst people are really nervous about it, it kind of takes one of our, I suppose, our tools away from us in terms of trying to get people out of their cars. And I perhaps would like to come back at a future meeting and talk when I've had a bit more time as the chair of the Air Quality Board, but also a bit more time in post non-COVID.
I think I agree with you.
Oh, Graham, you're muted.
Yeah, I agree with what you're saying. There are things that we can change, but I think things like employees not having to go into work every day, I think there are opportunities now to work at home. You wouldn't want to do it all the time, because I'm getting fed up with working at home at the moment, if you can't talk to your colleagues. But the idea that you may be able to work at home 1 or 2 days a week, that's less commuting, and if employers could encourage their employees to do that, and allow them to do that, that would help. That would be a great help. Yeah. So thank you. Yeah.
Thank you, Graham. Vivian, hi. Over to you.
Yes, thank you. Hi, Helen. I haven't. You have a slide here regarding the childhood obesity programme that was planned. Obviously now, not so many children go to school, and probably now not going back to September. Just wondered where you are with that programme, and has it slipped at all? Thank you.
Ooh, I might look to bring in my colleague. I've got Dominique, who's with me, who's one of my public health consultants. Because as you know, when the programmes, a lot of the work that we just presented on the slides started, I wasn't in the team. I'm aware that, so I might bring in Dominique to answer that. But can I just say, because I do think it's important, actually we do have quite a high percentage of children still at school, so key workers, children remained at school for that. And also we have seen, a number of, all of our schools opening up and now taking some pupils. I'd also just before I pass it on, I'd like to say that we have seen another positive, you can say that word, from COVID-19 is that we've seen more families exercising together and using opportunities in our green spaces, which again, we've got some good data and evidence to show, which has been heartening in a way that perhaps we haven't seen over the last few years. Dominique manages the lead for obesity, so I'll pass to her now.
Okay.
Welcome.
Thanks, Chair. Thanks, Councillor Atwell. So yes, we had a big programme planned for childhood obesity. Our Director of Public Health report from a couple of years ago highlighted that childhood obesity still continues to be an issue in the city, and we have higher than national average rates of obesity right across the city. One of the outcomes from that, when it was delivered to the Health and Wellbeing Board, was we were charged with producing an action plan to combat that. One of the actions was a so-called super zone, which is a concept developed in London, which looks at a very local area, in our case, with the Charles Dickens area of the city, which has one of the highest rates of obesity, childhood obesity. And it aims to align community work, local government policy, and also voluntary sector activity to really focus on what we know to be the drivers of obesity in terms of food, poor quality food, and lack of access to healthy food, limited physical activity, and safe places to play and to exercise. So we had a big work stream planned with partners and from the council and other stakeholders. Crucially, local children were very, very keen on this. We focused it on Arundel Court Primary School. And the week of the launch was the week we went into lockdown. So unfortunately, we were hoping that we will be able to resume that piece of work, which is all centred around Arundel Court Primary School, in a year's time. We've gone for September 21. We recognise, as you just said, children won't be back in school until September this year, and we want to give the schools really a chance to get to grips with the new normal there. So we've agreed with the school that we'll be starting again in September 21, and I really hope that we'll be able to build up some groundswell of support for that programme, because it was potentially very exciting.
Okay, thank you. I just wanted a supplementary, if you don't mind, probably back to Helen. You mentioned that obviously now families have been more active. Do you have any plans to probably encourage that in the future? It'd be great if we could.
Yes, we would like to, and again, obviously through things like the super zone, but we do want to be and the work, actually I'm going to pass that to Dominique, because she's leading on active travel and all of the work we're doing around physical activity.
Okay.
Dominique.
Yeah, so obviously the super zone is one strand that's focusing specifically on childhood obesity. Physical activity is a much broader piece, and we work very closely with colleagues in transport and in planning to make sure that active travel, and that so-called sort of incidental physical activity, which is the kind of physical activity you do on a daily basis to commute to work or to school, to go to the shops instead of going in a taxi or going in a car, is really accessible to everybody. And so one of the interesting outcomes from COVID has been the emergency transport plan that's obviously closed some streets around the city to enable social distancing, and that's also enabled more cycle lanes to pop up, if you like. And also a plan for part of that plan is to enable more school streets, which is the closure of streets around schools at pick up and drop off time, which has numerous benefits in terms of reducing road traffic accidents and in terms of reducing air pollution, but also in terms of travel and fostering that walking and cycling to school. So there's potential there as well for more incidental physical activity as actually as part of the COVID response.
It'd be interesting, Chair, if we could possibly to have some data on that in the future, maybe after 6 months or next year sometime.
Absolutely.
If possible.
I mean, there's huge interest in active travel at the moment. I would welcome some feedback quickly, actually, if we're going to do these things. So Helen, Dominique, if you're able to come back to HOSP soon, actually, probably sooner than later, I think that would be really helpful.
All right, thank you very much.
Thank you, Vivian. Is that okay? But coming back, because I think active travel is of interest at the moment, and in terms of public health, it would be useful for the panel to be up to date with what's happening. Good. Any other questions from members? Okay. Thank you. Thank you, Helen. Thank you, Dominique, as well. Look forward to having you back at panel soon. We will move on. Thank you. Andy's popping up. There we are. Hello. So an update from Adult Social Care, introduced by Andy Biddle, Assistant Director of Adult Social Care. Andy, welcome. Rather like the other presenters, thank you for your report. Is there anything you'd like to update from its contents?
I think it's probably difficult, Chair, to update from its contents because we covered a specific time period up till March, and everything since that particular fateful week has been COVID-19 related. So we have carried on some of those objectives and projects contained within the report as best that we can. But I think what we're seeing at the moment, in common with many services, is moving into a phase of recovery. Now, we would normally expect to see recovery to what we call a new business as usual, but we know that that's going to be staggered because we understand that this pandemic and the disease will be with us for some little time to come. So I think what we'll see is various steps in that journey to recovery. We still work very closely with our health colleagues, as is stitched through that report, both in the Clinical Commissioning Group and in Solent NHS Trust. And I guess I'd reflect on the submissions both from Mark from PHT and from Nikki from Southern Health. And if our Solent colleagues had been here today, I think they'd say the same thing. One of the really positive parts, if there is something positive to come out of the pandemic, has been that joint work across the city, so that we have worked truly as a health and care Portsmouth function, and have been able to support not only our residents but also our providers, private providers both in residential care and in domiciliary care through the pandemic, and help them support the people that we care for in our community, those of us with care and support needs. We have moved on. There's the social work duty project is mentioned in that report. We have moved that on thanks to COVID, really. We moved that up straight away without waiting to do the planning for it. And we also moved our adult multi-agency safeguarding hub alongside our front door, our social work duty, and dealt with our calls directly rather than routing them through a help desk. And that's been incredibly successful because we've been able to talk to people and help them resolve things first time, rather than do an initial inquiry and then pass that inquiry back for further work. So we've been really pleased to be able to do that, and we're still developing that offer and understanding the learning that's come from it. In terms of the market, both domiciliary care and the residential care market in Portsmouth, we've had very, very regular interactions with our providers. So we've been meeting with our care home providers on a weekly basis with our colleagues in the CCG. We've been meeting with our domiciliary care providers on a fortnightly basis, and with those providers that provide things like daycare or supported living, we've been having sort of 2-3 weekly catch-ups with them, and so that's something that we will continue to maintain, those very close relationships and that very contemporaneous communication about challenges and issues within the sector. What we've also been able to do is to provide a financial guarantee to our providers through some of the government funding that's been provided around COVID. The main thrust of that has been something called a minimum income guarantee. So we based our figures 3 months prior to COVID, and said to our providers, if you fall below that level in terms of income, we'll make sure that that's topped up. And because one of the real risks across the sector, both in domiciliary care and in residential care, is provider failure. I think nationally that's very well reported. Locally, we don't have quite so many shocks to the market because we tend to have small independent providers, whereas nationally you do get a lot of big providers, but we still have had closures and exits from the market in the past sort of 2 to 3 years, so it's really important to do that. I think we've talked about in the report developing a dementia extra care facility at Edinburgh House. We're still pursuing the planning of that. We've got some cost issues to resolve with that, but we've got some meetings coming up with Cabinet and with colleagues in regeneration to keep moving that forward. So we're still on track to build that unit. And in terms of our integrated localities, which was a project that we were working in conjunction with our colleagues with Solent, we're no longer co-located because nobody is co-located because there aren't really a lot of people in offices currently. And so we had a meeting this morning to move that forward virtually so that we're still continuing to work very closely together, but building those bridges that we can't have by sitting next to each other, if you like. Our medium-term financial strategy is due for a refresh with the impact of the pandemic on council budgets. We're not sure what the future holds for us. We know we've got a significant black hole in Portsmouth. We've seen various promises from government, both in terms of the 3.2 billion that was granted earlier this year and the 500 million non-ring fence grant that's been announced, I think it was last week, and the agreement to cover some lost income, but we still anticipate a significant black hole, and therefore a lot of our future plans will have to be predicated on what we can afford alongside working through our statutory duties as we always do. Our numbers are growing as they always do. That's a good thing in some ways because our numbers are growing in domiciliary care, so we're caring for more people at home than we ever have done before, and even through the extra care that we had to put on through the last 2 or 3 months, that was 75% of that was in domiciliary care. We didn't see all of that go into residential care, which was really positive for us. We were able to stand up some extra domiciliary care and keep that helping and supporting people in their own homes, which is really key to what we try to do. Our numbers are going up. We're still seeing a lot of people we helped because of a direct result of COVID-related infections still need ongoing care. That will have an impact on us in the future and will be one of our big challenges, I think. I think just looking through the report, deprivation of liberty safeguards, we haven't got the figures more recently, the end of the last financial year, but we know they're increasing, and we know that the liberty protection safeguards have been delayed until April next year at the earliest. That will be a very significant project because it changes the way that we do things for people that lack capacity to make decisions for themselves and have to live in a certain place. And then finally, we will have acute hospital pressures this winter, as we always do. We're in a better place than we've ever been, I think, as Mark reflected and Nikki reflected as well, with the partnership working that we've got to get people out quicker, to get people to the destination they need to be in. We also have a project at the moment that we stood up in relation to COVID, which was to care for people in isolation at Harry Sotnick House, similar to the Woodcott project that's mentioned earlier. We'd like to try and maintain that if we can, so that people don't have to make a longer term decision from a hospital bed, and we can bring them into a supportive and re-abling environment to be able to make decisions about where they go in the future. That's a brief canter through an update on where we are with some of those issues now, and happy to take any questions.
Appreciate that, Andy. Thank you. Over to you, Arthur.
Thanks, Chairman. It's on 2.4. My question is, you're looking for a pilot provider. How's that progressing?
We think we've identified the provider, the domiciliary care provider. We think we've identified the technology provider, but we need to bring those two together, make them work and issue the contracts. We were discussing this with Councillor Heaney the other day on a different call. So we are further forward than we have been, but COVID has impacted on that, so we're not as far forward as we'd like to be. We did a small test of that domiciliary care system with a provider that we directly employed, and we now finding a provider is to test it in the wider market so that we can understand if we can roll that out across the whole domiciliary care market in Portsmouth. So we're not quite there yet, but we've identified the 2 providers we think we need to use. We have to sort contracts and ensure that the operating system can support the work.
We shall look forward to an update from you. Thank you.
It's not at all. It's a really positive piece of work, and we're very enthusiastic to try and get it stood up rather than commissioning time and task blocks. So absolutely.
Great. Thank you.
Thank you, Arthur. Graham? Did you have your hand up? Oh, you're on mute. You're on mute, Graham. My lip reading is not.
Andy and I have had lots of conversations over recently, but I don't think I need to ask you.
Do you want another one?
No, no.
I thought your hand was up at one point.
No.
Okay. Any other members have anything to ask Andy on his report or update? No. Andy, thank you very much.
Thank you, Chair.
For keeping us up to date. Looking forward to you coming back in due course. Thank you. We move on to our last item, the update about dental services in Portsmouth. It's obviously a written update. Have we got any questions we'd like to ask of NHS England dental services, or do we want them to come in September to answer questions? Yeah. Anybody, any sort of desperate questions that we need to email them? Leo? Oh, Leo, you're on mute, Leo.
No. I don't think I haven't got any questions, but I think I'd like a full report once they've done this work. So I'm with you. I think we should ask them to come back at a future meeting, whether it be September or sometime later. Yeah.
Yeah, I agree with that.
Yeah, we all agree, I think.
Happy to second that, Chairman.
Thank you, Arthur. Okay, we'll invite somebody from NHS England Dental Services to come and update us, hopefully in September or after that. Thank you. Anything else from anybody before we wrap up? Leo?
Yeah, I just want to confirm that the thanking the staff who've been involved during COVID applies to items 4, 5, 6 and 7. So it'll be a template, that's all, just with the names of whoever the presenters were at the time. So I didn't want to put that in without, so that will be in the minutes if everybody agrees with that.
Yeah.
Okay.
Good.
Yeah. I'll send on the template for that. Yeah.
Thank you, Leo.
Great.
Thank you.
Agree with that.
Thank you.
Well, I think we got there without too many technical things happening.
Well done, Chair.
I wish I could take the credit. So thank you, everybody. That concludes, I think, today's HOSP. Our next meeting is to be held on the 17th of September, and who knows, we might be meeting in person. We don't know. Nice to see you all. Take care and look after yourselves.
Thank you very much.
Thank you. Bye.
Thank you. I'll ask them to formally end the meeting now. I'll ask them to stop recording.
Okay.
Thank you, Anna.
Look forward to seeing you all in September.
Thank you.
Bye.
Bye-bye.
Bye. Bye.
Okay, cheers.
Yeah, it's stopped recording.